So I'm going to talk about minimally invasive spine surgery today. So the key word here is minimally invasive. Why is this a key word? Because this is what changing the entire scope of our practice. This is what is making the surgeries more affordable for the patients, with quicker recovery, faster return to their work, and making it also less traumatic for the entire body, less traumatic for our spine. So it allows us to recover quickly and to return to the regular activities faster than before. So we establish, so it's something new what we have here. Prior to very recently, we didn't have a spine service. We established a spine service a bit more than a year ago. Our first case were performed in March, and we started having regular spine surgeries from May 2023. So we are like a little bit more a year and a half, I would say. So why it is so important to have a spine surgery service here? So as you know, so everybody has back pain, right? So in fact, there is a good statistics that everyone, 100% of population, they struggle from back pain or neck pain at some point in their life. So only in the United States, 6 to 7 million are disabled due to the spine conditions. So 6 to 7 million, it's a huge number of disability only because of the spine condition. And the number of lumbar surgeries has increased dramatically over the course of several years, so I would say next 20 years. So in comparison, if you compare with the hip and knee surgeries, they increase only 15%, but the spine surgeries increase more than 100%. This is another statistical data about the spine surgery. So could you imagine that in 2023, the spine surgery market was valued more than 10 billion? More than 10 billion. It's huge. And projected it's going to be 16 billion in 2023. So huge amount of money is spent on addressing spine condition. And what are the current trends? Current trends are, again, we are shifting away from major surgeries. We are shifting away from large incisions. So current trend are minimally invasive techniques and outpatient surgeries, which means, again, same like with total joints, right? So probably you have heard about hip replacement or knee replacement surgeries, and I'm sure some of you have hip and knee replaced. So before, when we started doing hip and knee replacements, like 20 years ago, patients used to spend how long in the hospital? Guess a number. 2 weeks. Then it became 1 week. Now we are discharging patients same night or next day. So if patient is spending 2 days in the hospital, means something is going slow. Okay? So we came to the same understanding with regards to the spine surgery. So patient needs to spend less time in the hospital. How to do it? Do the surgeries minimally invasive and do it outpatient. And if you look from that perspective, Monadnock Community Hospital is a great spot. So we have all the facilities here to do outpatient surgery. We are not a large hospital, but we are very well equipped with all necessary equipments. We have great staff. We have great anesthesiologists, nurses who are taking care. We have outpatient services. So from that perspective, our hospital is exactly on the perfect spot. And enhanced recovery, I talked about this also. So our anesthesiologists, our nurses, they are making sure prior to surgery to optimize the patients, as well as after the surgery to have them recovered faster. So these are some other trends which I'm not going to stop. Probably I'm going to like a little bit about the regenerative biologics, tissue engineering. So all this we have here, we are using and we have available. So rates of lumbar spine surgeries increased dramatically, especially for the patients who are 60 and above. Why is that? So look at these photos. So those are the generation of my grandfather, grandmother. So sitting on the porch quietly enjoying their retirement. This is your generation. I'm not joking. So now people want to be younger, and they are younger. They want to be much more active. They are jogging. They have good resources to take care of your health. They have good resources to be fit. They have access to information. They have access to healthcare. I should say you. And I mean, I had a patient who came to me and said, "Doctor, this week," and he was 88. "This week I climbed Mount Monadnock only 2 times instead of 6 times because my back hurts. Please do something." So you wouldn't have this scenario like 20 years ago, right? And it's a cultural change, which is great. And of course, if patients are trying to be more active, our body undergoes like wear and tear changes, right? So what is arthritis in the spine? It's wear and tear changes. We have lots of fancy words to describe like spine conditions like degenerative disc disease, facet arthropathies, like spinal stenosis, disc pinching, nerve pinching, sorry. I don't like these words. I'm telling my patients, see, spine is undergoing certain changes. And I usually compare this with the wrinkles on our face, like with white hairs. So this is happening in the spine too. And some cases it's okay, our body is tolerating, but some cases it's manifesting with pain and other issues, which we need to address to keep patients here on this square, not there, right? Of course, if patient is above 65, they have some other conditions, like heart conditions, pulmonary conditions, kidney, maybe like renal issues, and overall body is more fragile. And from that perspective, 65 years old won't tolerate a large surgery, but 65 years old will tolerate a minimally invasive surgery. And that's why we have a so increase of number of minimally invasive surgeries. Why? Because we can do a safe procedure. Someone who has like cardiac condition, heart condition, someone who has diabetes, someone who is overweight. So minimally invasive surgeries, oftentimes they are negating that negative effect of body being overweight. So this is our statistics. So from May 2023, less than 2 years ago, a year and a half, we did overall 92 cases. So where is Alicia? So we are preparing to celebrate the 100th case, which we'll do in Monadnock Hospital, which is a huge number, or that, a significant number. So since then, we have done 92 cases. So this is the breakdown of the cases. I want you to concentrate on this one. Almost 40% minimally invasive. So that's what we are concentrating on. That's what our emphasis is on to progress with that surgery. So most of the patients got discharged either on the same day or the one night stay after in the hospital, and there were no major complications. So what are the surgeries we are doing? We do cervical disc replacement, which is one of the newest cutting-edge surgeries where instead of fusing the cervical spine together for some neck pathologies, we are using cervical discs, which is here you can see one of the example of the cervical disc. It's a porous coated titanium with ceramic core, and it allows for a movement. And it's we have lots of new data in our literature which shows that it's superior than the fusion, which is much better procedure. And that's what we are performing, one of the procedures. This is, again, one of the cases performed here at Monadnock Hospital. You can see this little thing here. This is a ceramic core, and this patient underwent 2-level cervical disc replacement. This is another type of cervical disc, again, performed here. This for a younger patient. I'm just showing this one also just to stress that we are using different type of implants depending on what type of pathology. And this is very well known spine company, and their representative recently told me that we are the only hospital north to Boston who is using these new implants, which is something really really cool. This is a fusion procedure. Again, in some cases we still do fusion, but it's still minimally invasive. So it's done through the small incision on the front of the neck. Patients getting discharged home the same day or the next day. They start walking immediately. It's pretty quick and fast recovery. These are the X-rays after the fusion. Look at this. This is the spine. This is the open surgery. This is minimally invasive surgery. Which one would you prefer? To have large, open, deep wound, or just a small tube? Usually I'm not using the pictures from my operating room for non-medical audience because it might be too graphic. But this is a real picture from my operating room. So you can see this is the head of the patient is here, legs are here, right side, left side. This tube diameter is less than 1 inch. And this is the tube which goes down to the spine. The entire surgery is done through this tube. And again, instead of doing these huge incisions, now we perform everything from this small tube. Patients have, again, like 22 millimeter incision, less than 1 inch. They stand up immediately, they ambulate immediately. Most of them, they go home same night or the next day. Dramatic changes, so everyone loves it. Our anesthesiologists, nurses love, patients' family love, patients' employer love this because they go back to work much faster. So again, these are some other photos from the operating room. Endoscopy, this is another cutting-edge technology which we are utilizing here at Monadnock Community Hospital. Here incision is even smaller. It's 8 millimeters, which is like head of the pen you are holding. So the instrument is not a little bit bigger than that, which goes down to the spine. Here's one of the photos again. These are the X-rays from the same procedure. It shows again the same procedure, which is performed. It's animation of the same procedure, like minimally invasive endoscopic surgery. With that surgery, which I'm talking about, that very small injury, very small incision, so the infection risk is decreased 16 times. So it's literally, strikingly rare to have infection after this type of minimally invasive surgery. So significant decrease of pain. So patients rarely require opioids. So you know all about the negative effects of the opioids. They rarely require opioids. Of course, quicker return to work, negate the effect of obesity. I mean, probably you have heard that if patient's BMI is more than 40, this is increasing the chance of complications. And oftentimes we send patients back home to have some weight management, then come back to have a surgery to avoid the complications associated with that. So while using this minimally invasive technique, we say that it negates the effect of obesity. Why? Because incision is very small. The injury to the tissues is very small. The healing is much easier. And you can do safer procedure for this type of complicated patients. And it allows us to avoid large procedure, which is again a big gain. If you look at this graph, these are the publications about the spine endoscopy starting from 1976 to 2020. So you see a dramatic increase here. Why? You might ask why. What happened? Technology developed. All these tubes, all these small instruments, what we are using, they are dependent on the technology advancement, they are dependent on the scientific discoveries, and as the time progresses, we have more and more instruments which are much more versatile, much more efficient, much faster, much sharper, much cleaner, and allows us to visualize everything better and progress with surgery. So this is a little bit statistics. So endoscopic versus open discectomy. Let's say if patients, so we compare patients who have a disc problem, and we compare patients who underwent with disc problems endoscopy and regular surgery. And you can see decrease in hospital stay from 3.8 days to 0.9 days. So three days less in the hospital. A decrease of surgical time, like it's a 45 minutes procedure instead of an hour and a half procedure. And decrease of opiate consumption, I talked about that. Yeah, recently I traveled to Seattle. That was a big spine endoscopy conference, and I gathered some data from there. So for me, it was surprising to learn that approximately only 3% of spine surgeons do endoscopy on regular basis. And if you do a little bit stat, you will find out that in the entire United States, there are only 150 to 200 hospitals who are offering endoscopy on the regular basis, and 7 to 8 hospitals in New England, and we are one of them. So it's a big achievement, and we are really proud of that. And we're going to continue to progress to emphasize all our efforts on minimally invasive procedures to provide the best possible care to our community. And here is us, the Monadnock Community Hospital. I also put it there. This is another procedure, which is again minimally invasive procedure, pretty straightforward. We are doing this when patients have vertebral fragility fractures, when the spine is breaking due to weak bone. You know, the osteoporosis is one of the epidemics of 21st century, which means that the bone is really weak, and especially is getting weaker in the spine, and it results to simple fractures, like patients can sneeze and have a fracture. They can lift a really like chair and sustain a fracture. So it is associated with significant pain, it is associated with significant disability, and by performing this simple procedure, which is implantation of bone cement into the broken vertebra, we allow patients to immediately stand up, walk. They are getting immediate relief of pain. So it's a really satisfying procedure because it gives immediate results and it stabilizes the spine. Again, it's done through a very small, teeny tiny, it's not even incision, it's a small like puncture wound like the tip of your pen. Yes, ma'am?
Why is it, you're saying the last century, this is new?
It is.
Yes, and I was thinking first it's age, but it can't be because I have a lot of relatives from way back who lived a long time. So why is...
I don't think he's saying that osteoporosis is only in the 21st century.
Say again?
I don't think you're saying that osteoporosis is only a 21st century problem.
No, that's absolutely correct. Yeah, I apologize. It became epidemic now. Yes, of course, it existed before, absolutely. But we are seeing more and more patients with osteoporosis.
Why?
Excellent question. First, because of the increase of the age, increase of activity of the patients. And there are some other factors like nutrition plays a great role, genetics plays a great role. There are some other factors also, but we are seeing more and more osteoporosis. And the main reason we believe it's an aging population. It didn't appear now. It was there since before. Yeah, absolutely, you are right. Yeah, thanks for bringing this up. Okay. Yeah, sometimes we can do also like really big procedures, minimally invasive. So sometimes we can put all these screws and rods and cages into the spine with minimally invasive technique. Again, this is something relatively new, and as we progress, as we develop newer implants, we are getting better and better on this. So before, this procedure would involve one huge like 5-inch, 7-inch incision into the spine, with patients spending like 3-4 days in the hospital with prolonged recovery, so up to 3 months. Now again, with these new instruments, with new devices, with better implants, we can do this minimally invasive, and patients ending up having like one 2-inch incision here, one small incision there, and here we go. We do all the fusion without damaging or injuring the muscles or destabilizing the spine. So this is just to demonstrate how we can do extensive large procedures with rods and screws with minimally invasive technique. And if I do this surgery, again, patients get, we have done several, and patients just getting up, walking same night, being discharged home next day. So really good results. So overall, after 18 months, I should say, yeah, a bit more, we have 92 surgeries. Our complication rate is 3 times less than national average. So our complication rate is here, 5.8. This is the national average. Why is that? First and foremost, because we are doing it minimally invasive, right? We are not doing like major incisions. We are not doing major surgeries. And let's not forget, we are a community hospital, critical access hospital. We don't have that large ICUs which can support large surgeries. So, of course, bigger the surgery, more complications. We are not moving there. We are not going there. We just keep it everything minimally invasive, as minimal as possible, as efficient as possible. That's why we have so low complication rate. And also we have great staff to support us. This is the second reason. We have great OR team who is taking care of our sterility. We have great nurses, anesthesia support, clinical support staff. We have great marketing team. We have great administration who is, again, supporting all our initiatives. So it's all teamwork. And someone who has worked in many different larger hospitals in different parts of the world, I can reassure you that we have a great coordination, awesome team, awesome different departments who are working all together for the same single goal, to provide the best care for our patients and for our community, most importantly. And yeah, this is our staff, all our team members who are contributing to our success. And we have several procedures which are performed first time in the region. Again, it refers first of all to the spine surgery. And we continue to develop. And I'm sure as the time goes by, we're going to bring more and more high-tech technologies and procedures here, again, to ensure quick recovery and fast and safe patients' care. That's it for tonight, and I'm ready to answer your questions. Yes, ma'am. Mm-hmm.
What are your complications besides infection?
Good question. So there are certain complications which are typical for every type of surgery, right? Regardless, it's a spine surgery, it's a hip surgery, knee surgery, or let's say abdominal surgery. So infection is the first, a blood clot is the second. And remember, all those complications which I'm mentioning, they are much less with minimally invasive procedures. So blood clot is the second. Specific for spine surgery is what we call spinal fluid leak. When we have spinal fluid leak after the procedure, and I will tell my patient that this is one of the most common complications, which is approximately 5 to 10%. And if it happens, we're going to repair it, and patient's going to spend one night lying flat in the bed without head of bed elevation for 24 hours. And the next day, usually, we're going to gradually elevate their head, and they're going to start walking around. So if spinal fluid leak happens, they're going to spend one more night in the hospital laying flat. And usually, in the majority of cases, the treatment is successful, and it does not impact the long-term results, even the short-term results.
So is this spinal fluid leak a higher incidence with this minimally invasive surgery because the visibility is less?
Excellent question. Yeah, excellent question. The answer is no. In contrary, it's a hole, but we still have a great visibility. There is no strong evidence that it's more than with open surgeries. But we have a good evidence that because the incision is small, it's more easily recovered from that. Sometimes when you have a larger incision, for the body it takes longer to seal the wound, but with minimally invasive technique, it's easier to recover. Yeah, it's nerve injury is another complication. I will tell to my patient there is a possibility of the nerve injury which can be permanent or transient. But again, it's very rare. We did not have any nerve injury among all these 100 cases, almost 100 cases which was performed. So, yes, please. Yeah, I don't. Yeah, there are certain techniques starting from a simple stitch and finishing with special patches, like artificial patches, which we use to put on the spinal canal to seal. And other than patches, we have a special wound sealants, which we use also. So oftentimes we use all these three together: stitch, then patch, then sealant. So.
How can you tell if it leaked?
I see it. We see it during the surgery. Yeah, you see it during the surgery. It's a white transparent fluid which is coming out. So yeah, it's easy to see. Yeah. Yes, please.
If you have neck pain, what is the procedure to diagnose the problem? MRI?
So most commonly, yes, there are two modalities which are really important. First is the X-ray, and of course the MRI is the ultimate modality to diagnose the nerve pinching and arthritis. Sometimes, not sometimes, if patients this patient needs to have a surgery, I always obtain CT scan also. But most of the times the MRI is the most informative diagnostic tool. Sometimes, in some cases, we use electroneurommyography, but again, MRI is the main tool. Yes? Yes, please.
What's the imaging you use in the operating room to guide? Is it CT?
It's a CR. It's an X-ray.
It's a regular X-ray.
It's not a regular X-ray, but it's an X-ray image which we obtain in the operating room. Mm-hmm. So these are the examples of these X-rays. These are intraoperative X-rays. So we identify the level, we put a guide there, and we insert the dilator, and then we insert our instruments. So it's an X-ray along with endoscopy, along with camera visualization. Yes, please, ma'am.
When you're saying doing the cervical fusion and inserting that little shock absorber, how do you affix it to the surrounding bone?
With screws.
Always screws?
Yeah, excellent question. Yeah. You see, this is the shock absorber. These are the screws.
Okay.
And this is another option when, again, this is what you call, it's not a shock absorber, it's a titanium cage which enhances the fusion between two vertebrae, and we fix them with screws.
And what if there's a lot of osteoporosis, which is like Swiss cheese bones?
Oh my God.
You have to get...
You ask so great questions.
You have to get bone from another part of their body or from a cadaver?
So yeah, your questions are perfect, amazing questions. Thank you very much for bringing this up. So osteoporosis is a big problem. The Swiss cheese bone is a big issue to the extent that in some cases, if the osteoporosis is really significant, we don't do surgery, or we don't use the screws or hardware, for instance, because the chances of screws cutting off and creating more complications are so high that we prefer not to do it. Usually it's a problem for lumbar spine, not as much of a cervical spine. With regard of cadaver bone, now we have, for instance, for cervical spine, I don't use cadaver bone. I use an artificial protein which has capacity to enhance the bone growth. And it's a great, works great. It's very good bone graft substitute or artificial material which is simulating bone growth. Some cases we use, yes, cadaver bone, but it's not like cadaver bone sounds a little bit gross, and oftentimes people they might have a wrong impression. Yes, it's obtained from the cadaver, but it's undergoing. It's undergoing processing to the extent that it maintains only the matrix, only the important structures and cells, so it will enhance the growth. So if we do cervical disc replacement, we don't use any screws. As you can imagine, we need to have movements here, right? And you see these little spikes? Yeah, so you see these little spikes on the back of the implant, and they're teeny tiny spikes here, right? So this is how it's fixed in the bone, with these spikes. And we do it what we call press fit, which means we destruct this segment, then put the implant, then let it go back, and just under its own weight it compresses. Same with this one, so it has like spikes here, and this surface is it has special coating which allows the bone to ingrow into this surface. So after like we usually say 8 to 12 weeks, there is some bony ingrowth there, and it's becoming part of the bone, so it's very stable, becoming very stable. Yes, please.
You said it's only an inch wide to go down through. So these are very tiny components you're actually putting in somebody's body then? Because you got to get that down through that small opening.
So this one is a little bit bigger. No, this one goes from the front of the neck, so this is probably 2 or 3 inch incision. Here, this is indeed inch wide, and if I need to put something which is bigger than inch, then we do a little bit bigger incision. But usually to put screws, we do a separate incision, which is like 5 millimeters, a quarter of an inch. But most of the time, if we do this type of procedure, we don't put any screws or any implants. We just release the pressure from the nerves. So when we do this type of procedure or this type of endoscopy, we don't put implants through the same hole. If we need implant, we do separate small incisions, which is again much better than one huge incision. Yeah, but again, good observation. Thank you.
Do you make lab bones here? Because I had several made in Boston. They made them, they didn't come from a cadaver, they did them in a lab.
No, we don't do that. I know what you are talking about. No, we don't do that. We don't have that possibility. Yeah. Yeah.
You've talked about, excuse me, cervical implants and things like that. What if you have a very, so far I don't think, a very narrow cervical canal in your neck? Can this type of procedure or minimally invasive surgery still be done for a situation like that?
The answer is yes. If someone has a very narrow cervical canal, then we can do this type of procedure, the cervical fusions or cervical disc replacements here. But again, there are some cases, not some, I mean, there are lots of cases where I would say, you are not a candidate for, I'm sorry, but the patient is not a candidate for minimally invasive surgery. So lots of time, yeah, so of course there are some limitations. We try to do it more and more, and if you look at the general statistics and data, number of minimally invasive surgeries are increasing every year. But again, there are some limitations. I'm not excluding after 10 years, after 15 years, it will be much better given that the technology will develop. And what are those new technologies which I didn't talk about? Let's say, for example, it's robotics or navigation or these are like so much exciting. It's exciting fields of the spine surgery when, with special instruments, we can literally navigate our screws, our implants in the perfect position. When the robots are doing some cuts for us in again like very precise manner. We don't have robot here. We don't have a navigation, but again, this is something which is coming. This is the process in development. And every year when I travel to conferences, every year I see newer and newer robots, newer navigation systems which are much more precise, much more versatile, and allowing for much more sophisticated and complex procedure to be performed. Yeah.
So this is something, as these new things come up, that you have to go away for a mini training or whatever, right?
Yeah, it's an excellent question. The answer is and yes and no. So whatever is coming up is a new tool. We are not doing different type of surgeries. Surgery is the same, but we are getting new tools. Yes, you have to learn to use how to use the new tool, but the surgery in general is the same. Surgery, let's say, the decompression or laminectomy hasn't been changed. It's the same surgery as like 100 years ago, right? But before, like when I was like studying in the medical university, my professor, who was about to retire, he used to open the spinal canal with the osteotome, with the mallet, and with chisel. We don't do it now, but they used to do that because they didn't have like high-speed bursts. They didn't have that instrument, and that was a standard care at that time. And of course, they have like 70% complication rate. Spinal fluid leak was like 90%. Like nerve injuries were like much higher, right? But now we are talking new tools, new techniques, which allow to do the same things in much delicate manner. So again, surgery is the same. We are getting new tools. Yes, you have to get a training with the new tools, but procedure itself is the same. So that's why it's yes or no. And yes and no. Yes, please.
Just one more question. Oh, I'm sorry.
Yeah.
Was it me?
You mentioned robotics.
Yes.
What would be the cost for robotics, and would the robotics be usable? Because I know there are so many other robotics that general surgeons use.
Yeah.
Do they have to be specific to the
Spine, yes.
to the spine?
Yes.
And what's that cost?
Oh.
And are there grants?
Well, the answer to the first, yes, it's specific for the spine, yes. Costs, I know some numbers, but I'm not going to say it is very expensive. I know that it's worth, like for larger institutions, like for example, I came from University of Maryland, right? We have two robots there, so we're using that, so it saves some time, it saves some efforts, it allows to do more surgeries more efficiently, less complications, so it's somehow financially justified. Given that you are in the large hospital where you do like 20 surgeries per week, right? It's still justifiable for the small hospital also, but again, lots of moving parts involved there. It's not only cool tool to play with, but it's really making difference in patients' outcome. Yes, they are expensive, but again.
Some robotics have really revolutionized general surgery.
Oh, that's totally correct.
Improved it immensely. And would that be true for spine surgery?
Oh yes, absolutely. Yeah, totally yes. Of course, let's like they are cutting down the surgical time immensely. Of course, there is a learning curve to your point. Like, let's say, first several cases we spend learning how to use the robot, but then it cuts down the surgical time. It cuts down the It cuts down the complications. It's much more accurate, much more quicker. Yeah, the answer is yes. Yeah, and absolutely. This direction where it moves, where the surgery in general, spine surgery moves. Yes, please.
My last question.
I'm sorry, sir.
I believe that I read that with traditional spinal fusion, anywhere in the spine where they use the screws and rods and incorporate it, and if the surgery is successful, will it last just for 5 to 7 years because of wear and tear on what those screws and rods are affixed to? How long does this surgery last? Does it last longer than 5 to 7 years before it has to be redone again or not? Especially those little shock absorbers.
Okay, so let me talk about your first point. So again, it's a very, very good point. Obviously, I mean, you have good knowledge about the long-term outcome. So if you fuse a segment here, if we remove the movements from one segment, the segment above is getting much more load. And this segment above has a chance to develop a disease. So this chance is 2 to 3% per year, which means in 10 years there is a 25% of chance to developing what we call adjacent segment disease. So in 20 years, the chance is 50%, right? And if you ask me, are these patients, all of them, gonna need surgery? The answer is no. So only 40% of those who develop adjacent segment disease, they need surgery. So yes, your question is very, very correct. If you fuse, after 7 years, 10 years, there is a chance that the level above has a disease. And we always tell the patients, and we always try not to fuse. And there's another tendency currently in spine surgery. There are lots of people, lots of spine surgeons, there is a motto, I refuse to fuse. So, and lots of people, they would, I mean, I've seen this a couple of times. So when you say shock absorbers, you have very, very, very good point here. So when you compare the cervical spine fusion with cervical disc replacement, current data shows that disc replacement have much better longevity, much less adjacent segment disease. Why? Because we preserve the motion. And why I'm saying recent data, because cervical disc replacement is a recent procedure. Like for last 10, 20 years, like we started doing. And now only we are gathering the data enough to prove that this is much more superior than cervical fusion. Why? Because there is no evidence of adjacent segment disease. There is, the reoperation rates are much lesser with this procedure than with fusion procedure. So that's why this is becoming more and more widespread and kind of standard of care.
Is that like getting new walls between each one? They're more like this?
Yes.
Here?
Yes. Yeah. I mean, again, there are some limitations. So right now, probably, I'm still doing more fusions than disc replacements because there are certain other factors which we need to consider prior to doing the cervical disc replacement. But again, it's especially for younger patients who need fusion, this is a very, very good option. Mm-hmm.
Would you chance when you implant something that your body would reject it?
So there are rare cases of nickel allergy, which are described, but those are very rare. The answer is most of the cases no. The vast majority cases of no. So usually, if we see some reaction, it's infection. Usually, we are dealing with infection. Again, a very rare case of nickel allergy, which is yes, you can say that your body is rejecting the implant because it has nickel in it. I had recently one patient, a woman came with a fracture, and she said, I was preparing her for surgery. She said, "Doctor, I know I have a nickel allergy. Please make sure there is no nickel in your implants." I called my company guy. I said, "Hey, I have these patients. Does your implant has nickel in it? He said, let me get back to you. Same night he called me and said, you know, it has a little amount of nickel. I said, okay, sorry, I passed you. I call another guy, another company. He find out that their implant does not have any nickel in it. So we use that one. So this is a case, but usually patients, they know. Yeah. Yes, sir. Yeah.
Wait, how do you deal with narrowing of a vertebrae due to calcification or something like that?
Narrowing of the vertebrae?
Yeah, you know.
You mean the spinal canal?
Yeah.
Yeah, if the spinal canal is narrowed, that's what we call spinal stenosis. That's what is causing most of the problems. And that's exactly what we do. So the spinal stenosis is one of the indications for this minimally invasive procedure.
Okay, do you use the same technique, or do you use lasers, or what?
Yeah, we use the same technique, and we use this minimally invasive technique, and we use a burr to burr a little bit bone from where it's the most tight, where it's pushing on the spinal nerves, and this how we release the tension. If we need to remove part of the disc, we remove part of the disc. Yes, the principle is the same. So we do it minimally invasive spinal stenosis.
Mechanical.
It's a mechanical, yeah. It's most of the time it's a mechanical problem. It's a structural mechanical problem, like almost always. That's what we address. Yeah? Any other questions?
Thank you very much.
You are welcome. Thanks.